introduce our guest first. I'll say a few words, and then we'll really go in and hear from these great experts on some of the key issues of the day. So we have Dr. Jay Bhattacharya is a professor of medicine at Stanford University. He also has a PhD in economics, received his undergraduate degree in economics at Stanford, and his MD and PhD from Stanford. And his research focuses on the constraints that vulnerable populations face in making decisions that affect their health status, as well as the effects of government policies and programs designed to benefit vulnerable populations. He's published empirical economics and health services research on the elderly, adolescents, HIV/AIDS, and managed care. More recently, he has researched the regulation of the viatical sediments market and summer-winter differences in nutritional outcomes for low-income American families. He's also an expert that both government and private sector rely on frequently. We also have Dr. Martin Kulldorff, professor of medicine at Harvard Medical School. He is a biostatistician and epidemiologist in the division of pharmacoepidemiology and pharmacoeconomics, Brigham and Women's Hospital. His research centers on developing and applying new disease surveillance methods for post-market drug and vaccine safety surveillance and for the early detection and monitoring of infectious disease outbreaks. He's developed a lot of really neat things that I think the average person wouldn't quite understand, so I'm not going to, and I certainly don't understand, so I'm not going to read, but really amazing what he's been able to do. And then finally, we have Dr. Michael Levitt, Stanford Medical School professor of structural biology. He's a giant in the field of structural biology who's developed sophisticated computer algorithms to build models of complex biological molecules. He's also the recipient of the 2013 Nobel Prize in Chemistry. He has a PhD from Cambridge and has done an awful lot in his career, has been on a lot of scientific advisory boards from some major companies. But one of the things he's done is he was really one of the first scientists to identify some of the problems with some of these really extravagant models as applied to COVID-19, and he was able to identify the kind of the life cycle of the virus and how it was actually behaving. And I think his research really stood out in that respect. So why don't we start there? And Dr. Levitt, can you talk about, you've watched the virus, really you started following it in China, and then you looked in Europe, and then in different parts of the United States. Has there been a consistent pattern in how the virus has behaved? We heard a lot early on about potentially runaway exponential growth of the virus. Has that happened? And what would you say about some of these models that were used to really inform a lot of policy in Great Britain and the United States, models like Neil Ferguson's model from Imperial College London?
Well, thank you very much. It's great to be here. Wonderful colleagues, and you've been a great fan. So I should say that, firstly, I'm not an epidemiologist. I come to this as somebody who looks at numbers, understands models, and actually understands a lot of the biology. I know exactly what RNA is. I know what virus structure. So in that sense, I think I understand the virus pretty well. And I got into this by accident very early on. And in studying what happened early on in China, it seemed to me that this virus was a virus with its brakes on. It didn't seem to want to go very quick. It seemed to want to stop. It burnt out pretty quickly in Wuhan and Hubei, the provinces of China, the main city. And then, but basically my approach has been to simply follow the numbers, a little bit like a financial analyst would look at a market. He wouldn't necessarily maybe be a farmer in pork bellies, but he would understand the way the market worked by the numbers. And the numbers have been surprisingly consistent. I would say that perhaps with the exception of Iran, all the numbers have looked to me to make a lot of consistent sense. And basically, I felt that a number of things were done very early on that were, I guess, unfortunate, like calling this a novel coronavirus. Coronaviruses are not novel. We know them a lot. Common colds are coronaviruses. So this may be a new coronavirus in terms of that we haven't had this particular one before, but human beings do know coronaviruses. The other was that the initial death rates were quoted by essentially averaging very, very hard-hit areas with much less hard-hit areas. So in the city of Wuhan, where almost all the deaths were, the death rate was about 4 or 5% death per case. But in the rest of China, which is a much bigger area, it was less than 1%. So, averaging those two things and saying it's 3% is not necessarily a good idea. As for the predictions, this virus, it turns out that people, for whatever reason, seem to like the idea of exponential growth. And certainly, if I was investing money in a bank, I would love it to grow exponentially. The thing is that exponential growth for these virus models essentially means that an infected person manages to meet uninfected people all the time. So it's like you get infected, you're transported to a new area where there aren't any infected people. And this is actually not easy to do. As a result, particularly for coronavirus, where there are many undetected cases, normally when you come to a new area, people are already infected, so it's hard to infect them. So growing exponentially isn't easy. I was surprised by the predictions made by the Imperial College Group. Early on, they had said that the case fatality ratio, the number of deaths per cases, were 14%, whereas I'd never encountered any number like that in the data. And then when I saw their models, I was just surprised at how large they were. I was also surprised by the fact that I did actually try quite hard to engage with them. I came to the conclusion that British scientists have their email permanently on vacation mode. Whenever you write to them, you seem to be told that they're not dealing with emails. But this communication didn't seem to work. I eventually got through, and it wasn't very satisfying. I mean, I basically said their numbers were a factor of 10 too high, and they said they're not, and I just gave up because, they were the experts. But I still believed what I said. Overall, in terms of consistency, I think one of the remarkable things has been just how consistent the behavior of the virus has been. There's two sides to an epidemic. There's the virus and there's the people. And I think that people have been way less consistent than the virus. Now, that's not surprising because viruses are actually very simple. I mean, they don't, they're very, a little bit of RNA that tries to multiply. It is not a complicated organism. But even in places, I mean, we're hearing stories about places that you would have thought would be total disasters having become fine. So I think that all the evidence so far is that this virus is behaving well. But again, one always needs to remember that I guess like, your financial advisor tells you, past performance is not necessarily indicative of what's going to happen in the future. Who knows what could happen? A lot of unexpected things could happen. But certainly in every situation we've seen so far, things have been pretty understandable.
And what's the, I think you've looked at a number of areas. What has been the infection threshold? I think you've identified, you'll see the infections increase. And then once that seropositivity hits, is it the 15% window that once it hits there, you start to see it lose legs?
It's hard because seroprevalence depends on, it's something which changes with time, and it's not something that's actually very easy to remember. The antibody tests have different levels of sensitivity. I, again, not being an epidemiologist, simply said, we don't know what fraction's infected. Let's just assume what fraction of the population either becomes a case or, unfortunately, doesn't survive. And cases are very complicated because you can measure, I mean, a case in Germany is very different from a case in Italy. For every case in Italy, there would be 10 or 15 cases in Germany because of more sensitive measurement. On the other hand, if you look at most places, the places that have been hard hit, the number of deaths per million population is between, most of them are around 700 deaths per million population. That's a population death rate of 0.07. Some places, particularly in the northeast of the United States and in the northwest of Italy, have been about 2 or 3 times higher than that. So maybe 0.2% or something like that. But basically, this does seem to be the case. It's also true in places that have done nothing, like Sweden, or cities that have been done really nothing, like Manaus in Brazil or Iquitos in Peru. So, but again, this does seem to be a general trend. Now, whether this is herd immunity or whether there were a certain number of people who were fragile and didn't survive, or whether there's some kind of natural saturation, I don't know. But there does seem to be this. So in some ways, it was something that Sweden was a relatively late epidemic in Europe. By the time Sweden was about halfway through, we knew that in Europe, most countries were stopping at about 600 per million. And that number actually was exactly what Sweden got to. They got to 6,000 deaths for 10 million population. So this number does, but I think this number will vary. And again, the big puzzle is Japan, South Korea, China. These countries all have very, very small numbers, maybe 10 per million instead of a few hundred. We don't understand that yet.
Great. And Jay Bhattacharya, you guys at Stanford, I think, were the first to look at the antibody testing and try to figure out, because we knew that we had a certain number of cases. I think in February, most of the places in the United States, we assumed there were very few cases, very few infections. You'd test negative, okay, and then you'd end up finding some, and you think, oh, these are the cases. And I think that what you guys are able to show is for every case that may be documented, there may be 10 or 15 times as many infections out there, and part of that is a function of not everyone would even seek medical care. Many of these infections are very mild or even asymptomatic. So can you talk a little bit about what your research at Stanford showed in some of those studies in places like Santa Clara, and then what the implications are for a policy in terms of COVID-19?
Thank you. So I worked on several seroprevalence studies. As you pointed out, that the point of them is to estimate the number of people in the population that have been exposed or infected. Just checking for active cases provides an underestimate, because many people who get infected don't actually respond with a severe infection. Many actually have no symptoms at all. So these studies looked at how many people in Santa Clara County, Los Angeles County, and I also worked on the Major League Baseball study, but now there's 75 of these studies worldwide. And they tell a very, very similar story. There are many times more people infected than identified as cases. The range of infections range from completely asymptomatic all the way to the severe viral pneumonia, but that severe viral pneumonia is only a small fraction of the cases. So what you see in the news is just the very most severe cases. The mortality rate from the virus has an enormous age gradient. For the oldest people in the population, it's severe. I mean, it's somewhere in the order of 2 to 4 in 1,000, 2 to 4 in 100 mortality rate. Whereas for the youngest people in the population, it's less severe than the flu in terms of mortality rate. I mean, 1 in 100,000 mortality rate, or low, or even lower for children. These are all lessons you can learn only from studies like the antibody studies, because then you need to understand how many people are infected if you want a mortality rate. You want the denominator. And in fact, actually, that's interesting that the evidence is emerging that the antibody studies that I participated in and others probably overestimate the mortality rate, because there's some fraction of the population that has immunity to the virus through other mechanisms, not just antibodies. There was a debate yesterday between, you heard with Dr. Fauci and some of the other folks in the government. I mean, actually, the scientific evidence that's emerging is pretty clear that there seem to be other mechanisms, such as T-cell mediated immunity, that provide some protection to some fraction of the population. So and the antibodies studies don't pick that up, because we're looking at simply at antibody prevalence. You had mentioned one other thing about the 10 times. So the CDC estimates that there's 10 times as many cases. Their own antibody study says that there's 10 times as many infections as there are cases. So if we apply that number now to the population of that's roughly 7 million now, it says roughly 70 million people have been infected in the U.S. As probably as an underestimate is my take on it. So I think it's of course there's great uncertainty around that number because it's a population sample and not a count. But in some sense, that's really good news. 70 million people infected, and we have 200,000 deaths, which are really unfortunate. But the mortality rate from the death, the disease itself, is much lower than we saw in the early days of the epidemic. And I think communicating that clearly, that if you are infected, it's not an immediate death sentence. I mean, I think addressing that panic is really, really important. Giving people the truth about what the numbers are actually telling us regarding how lethal the disease is really important. And then taking into account the sharp age gradient, where the older population faces more of a risk from this than younger populations do, is also very, very important, I think.
And you mentioned the debate yesterday in that Senate committee regarding the role that population immunity plays in, and I think what the one senator was trying to just say is what role does that play in reducing the reproduction ability of the virus? I don't think he was trying to say the virus is eradicated, but as more population immunity is built up, it is maybe led to that in all these places. And I think, as you pointed out, the antibody prevalence is not necessarily the outer limit of what we would look at in terms of this. You touched on it, but there have been a number of studies. I know people like Sunetra Gupta at Oxford, Gomez over in Scotland, they've put together this, and they've looked at how the virus works in populations. And people posit the Asia results partially because people from 2003 that had SARS-1, they still have an immune response to COVID-19. So can you talk about antibody in Florida? We hit probably 25% on our testing. Now, those weren't scientifically representative. It's people that want to go in. It now has kind of gone down just because we have less prevalence. The protection is still there, but the antibodies may not be popping in these tests. And so that's one thing to look at, but then there may be other things. Can you just summarize what the state of play is on that?
Sure. So, there's still obviously a lot of work being done on this. One thing that it's very important to understand, antibodies in this, what the evidence is saying is the antibodies rise after you're infected to the disease. That, like most people that get infected will have some antibody response, and then that declines over time. The evidence is suggesting that, but at the same time, you're not unprotected after you've had the antibodies decline. Just some evidence on that is that we've only seen, I think, 2 reinfections out of millions of cases worldwide, right? So it's very clear that there's some long-lasting immune protection even after antibodies decline to SARS-CoV-2. And that's not magic. I mean, that happens with many, many diseases. Now, typically, antibody protection is more complete. So, you may get infected and then you have to completely see no symptoms. But this other T-cell mediated immunity will provide you some protection, actually a lot of protection. So you only have a mild disease and not a severe disease. And yeah, actually maybe potentially even more complete. So the news is actually very, very good. It looks like the disease is not as lethal as we thought. It's for young people, really much less lethal even than the flu. If a large fraction of the population, a substantial fraction of the population seems to have been infected and not died from it, and that's providing some protection in the population from reinfection, from being exposed to the disease. So just to give some sense of this, and to pick up on what Dr. Levitt said, if you have the disease, if you have you're positive, you actively have it, and you randomly run into 2 or 3 people in the population, and a third of the population or half the population is already immune, because they for whatever reason, then you're not going to infect. You're not even at risk of infecting only one of those 3 people at most, on that order. So it's those 2 people are already protected. I mean, so I think in some sense we're headed toward that. Now, now a lot of that has to do with how people interact with one another. So when things loosen up, you will see cases. The question is, who gets those cases? So if we protect the elderly, we limit the mortality, we limit severe disease, we've done a really good job. I mean, I think that to me is the crux of the thing, the age gradient between the high risk people who are elderly and the low risk people who are young. I mean, I think that's really the crux of the policy issue. how do you account for that age difference? And a policy that sort of asks the young who don't face a ton of risk from this and whose behavior doesn't tend to expose the elderly because they don't interact a lot with the elderly, I think is a mistake.
Great. Dr. Kaldorf, in March, there was a move amongst a lot of experts to embrace more draconian measures, lockdowns to, I think the purported reason at the time was to slow the spread enough so that hospitals wouldn't be overwhelmed and the medical system would have time to be able to treat people, and then obviously people who needed medical attention for things other than COVID do that as well. What can we say about the efficacy of these lockdowns? I noticed Peru had one of the most severe lockdowns, and I think they're number one in the world for per capita mortality. There were some other countries that did very little in that way, who have significantly less mortality. So how would you analyze how the role that the lockdowns have played, and have they shown to be able to really reduce deaths in the disease, or is this just something that they're pushing the infections out over a longer period of time?
Yeah, so back in March, it made sense to flatten the curve because we don't want to overburden the hospitals. And I think that was a success in most parts of the world, except I think Spain and Northern Italy. But if you do a lockdown beyond that, you're sort of pushing the cases in the future. And instead of sort of doing a lockdown that's general for the whole population, that doesn't make sense from a public health perspective. So instead, what Dr. Bhattacharya said is that we have an enormous difference in risk by age. So everybody can get infected. And but the risk for mortality is more than 1,000-fold different risk for the oldest people versus the younger. So for the older people, this is worse than the annual flu, but for children, this is much milder than the annual flu. Normally, we have a few hundred deaths of children dying from the flu every year, and that's much less here. And even in a country like Sweden, where they never closed the schools, all daycare and schools in Sweden was open from age 1 to 15 throughout the height of the pandemic there. And among the 1.8 million children in Sweden, there were exactly 0 deaths from COVID-19. So this is not a dangerous thing for children nor for younger adults. So from a public health perspective, what makes sense is we have to do as well as we can, and a lot better than what was done previously in many parts of the world, to protect the elderly, both at nursing homes, but also people who live at home or people who live in multi-generational families. So we have to do as much as we can to protect those high-risk groups. But children and young adults, they should be able to live lives normally, more or less. They should wash their hands and those kind of things, but there's no public health reasons to close schools. And I think these sort of general lockdowns of closing schools or closing restaurants or closing beaches or whatever, that actually have a detrimental effect on public health because we have less cancer screenings, we have worse outcomes from cardiovascular diseases, we have problems with mental health issues, there are more house evictions, and all of these are very serious public health problems that we are generating through the lockdown. And of course, it's primarily the working class who is suffering from this. So in a sense, we are protecting very low-risk college students and professionals who can work from home, while we are putting older working class people at risk because they have to work. And that increases the total number of deaths, of course. So that's not the smart public health policy to do here.
So would you say, whatever happened March, April, at this vantage point now, that these general lockdowns should be off the table?
Yes, and the focus should be on protecting the elderly. And we can see that, and the elderly has to be protected until we reach herd immunity. And herd immunity is not a strategy. So we will eventually reach herd immunity either through a vaccine or through natural infections, or most likely through a combination of both. So, and if we drag that on for too long, if that takes year after year, then it will be much harder to protect the elderly because they can't self-isolate forever.
Absolutely. Dr. Levitt, do you agree with that? The lockdowns at this point should be off the table?
Yeah, I also agree with the fact that, you know, a death is a terrible thing. It's not as if a COVID death is especially terrible. And I think that if we could lock down with zero cost to anybody, then maybe it would be useful sometimes. But the fact is that it's you know, a treatment that can often kill the patient. So I think that, especially as Martin pointed out, the vulnerable people are those who don't have the luxury of working from home or being able to have meetings by Zoom. If you're working in a restaurant or a gardener or any kind of service driving a truck, you have to be exposed. So I do think that we need to think carefully about how to protect the elderly. I think protecting the elderly is something which is easier said than done, because if a person is 90 years old, then even under the best of circumstances, there's a fairly high chance of dying. I mean, I'm 73, and I know that I have about 0.5% chance of dying every month. So that, you know, it adds up. But of course, it doesn't in any way affect my behavior. In fact, it makes me want to live more dangerously. If I bought a motorcycle now, the incremental risk would be very small. So there are some good things about getting old. You can do risky things because you have less to lose. But I do definitely think that for whatever reason, one needs to think about the whole picture. And I'm sure that Jay, with his economics background, would understand that you need to basically balance, you know, everything together. And this doesn't seem to happen very much here.
And Jay Bhattacharya, do you also agree at this point, lockdowns off the table?
Another lockdown would be disastrous, Governor. Right at this point, we know that the benefits of the lockdown are small. As Dr. Kolarov said, that all they do is push cases off into the future. It doesn't actually prevent the disease from happening. And the costs are absolutely catastrophic, enormous. And schools are a good example of this, right? Schools are places where kids get obviously education, but they get nutrition through school lunches and school breakfasts. They get counseling if they have psychological problems where abuse is picked up. Case people who don't go to the hospital because they're more scared of COVID than they are of cancer is a disaster. Parents who don't take their kids in for immunization. The lockdown costs are absolutely catastrophic. We know that for a fact. There's not uncertainty around that. Whereas we've learned from our experience over the last few months that the lockdown benefits are much smaller than we expect. Places that have lockdown, famously, like for instance, Argentina and Spain famously locked down very sharply, and yet they're still seeing a sharp rise in cases. Lockdowns are not a way to eliminate the disease. Lockdowns have never in history eradicated a disease, and they will not do that in this case either. And the costs are too high.
How would you characterize the efficacy of some of these things? They're called non-pharmaceutical interventions. I mean, obviously you have the draconian, some draconian Australia-style lockdown or some of these places, but then you also have business closures, some other types of mandates. What's the evidence that they've really been important in bending the curve? And I just mention this because, you know, the Sun Belt, we saw prevalence increase within a week of each other from Los Angeles to South Carolina, and different policies, different openings. They'll say, oh, well, Texas did this, but then I can point you to Georgia that did the opposite, and the epidemic curves are pretty similar. And so what role do they play in terms of bending the curve of an epidemic? Can we say that at this time, given that we do seem to have a lot of A/B tests that have happened?
Yeah, I mean, I think it's mixed at best. I mean, like things like hand washing, I'm fully in favor of. I mean, there's lots of good evidence on that from a long history. I think I want to distinguish in answering your question a mandate to do certain activities, like a mask mandate, from people naturally engaging in protective behavior. When people feel like there's some threat, some risk, they will automatically, naturally engage in protective behavior, right? So in places like Sweden, we see social distancing even without mandated social distancing, because you communicate clearly to the public what the risks are, and people will take those actions on their own. Versus a mandate that says we're going to fine you or imprison you or something if you violate this, if you don't engage in the particular behavior. From what I've seen in the empirical evidence, these mandates seem to be uncorrelated, like for instance, mask mandates, and be uncorrelated with disease spread, right? So you have places that have mask mandates go in place and you see cases continue to rise. Mask mandates are sometimes put in place during the decline in cases, and people say, oh, look, the cases declined, but the cases were declining even before. The path of the disease seems for the most part, as far as I can tell, that's just sort of uncorrelated with the imposition of these kinds of NPI mandates. But I said partly you can understand that, right? So people will engage in these protective behaviors whenever they think there's a risk. I think a better policy would be communicate clearly to the public sort of what the risks actually are at the moment, and let people make their choices. Like some people, if you're in a crowded area where you have no choice because you're working there, masks make a lot of sense. You should put them on. If you're outside riding your bike alone, I mean, what sense does it make? I mean, I think a mandate sort of has this sort of blunderbuss policy that imposes costs on it. And it's not just, I'm using masks as an example. I think it's true for lots of these NPI kind of mandates. You want to communicate clearly to the public what the risks actually are, what the benefits actually are, and let them make the choices based on the conditions that they actually face, as opposed to assuming that what's good in a hospital will also be good when you're outside jogging by yourself.
Dr. Kaldorf, how would you come down on some of these NPIs, particularly like business closures? Because I think you've analyzed Sweden. They didn't close businesses. A lot of places in Europe, Belgium, Spain, Italy, Britain, they did. And yet the curves are very similar. In fact, I think Sweden's is actually lower than some of those other places. So what role do you think those business closures played, if any, in bending the epidemic curve downward?
Well, I don't think it makes any sense to close businesses for young people. If people in the 20s, 30s, and 40s wants to go to the pub or to a restaurant, like they have been doing in Sweden throughout, that's a good thing. It's a healthy thing to do. And the people who should be careful are people who are the elderly, and they should avoid crowds. And I think as long as the elderly avoids too many contacts, then I don't see any problem with having businesses open.
Great. Here's a snapshot of Florida that kind of sets up my next question. So our COVID hospitalized patients has declined 73% since our July peak. The number of COVID positive patients in the ICUs declined 70% since the July peak. Emergency department visits for COVID-like illness are down to levels last seen in early June. Admissions for COVID just yesterday, one of the lowest since early June, but the discharges exceeded admissions by 20% throughout Florida hospitals. Florida hospital capacity, currently 24% of beds are empty, 23% of ICU beds are empty, and COVID-positive patients represent about 3.5% of all licensed beds. And I mention that because the initial rationale, as we had discussed, was to prevent this hospital overrun. There were models put out by Neil Ferguson, IHME, predicting tens of millions of hospitalizations throughout the United States. I think we've had about 600,000. And so at this point, is there anybody that thinks that COVID-19 represents a significant threat in terms of overwhelming hospitals in the United States. Professor Kaldorf, you want to start?
No.
Jay Bhattacharya?
No, it's the opposite, Governor. I mean, I think a lot of hospitals around the country have faced financial difficulties because they've been empty. I mean, they've been, yeah, that's at this point, certainly not.
Dr. Levitt?
I certainly would agree, but I think that we're in the minority worldwide. People are still locking down and engaging in, I think, behavior which is likely to be detrimental in the long run.
And I think...
but I definitely agree with this.
Dr. Bhattacharya pointed out about the rates in Florida. I mean, typically a hospital would want to run those ICUs at 90+%. And so be at 23%, and then to have 24% of the beds. I mean, again, they typically, before the pandemic started in Florida, we had 90% of our beds were in use at the beginning of March. And then I think what happened was a combination of the stopping of elected procedures towards the end of March, and then just the overall fear that people had in the frenzy. There were people who had really serious heart problems, and I think it still happens to a certain extent. I think it's gotten better, stroke symptoms, and they are actually just declining to go to the hospital. I think there was a fear of catching coronavirus, but then there was also this narrative put out that the hospitals were in fact overflowing with COVID patients. So some people thought, well, I don't want to go into the hospital for heart problems. The COVID patient may need the bed. And in fact, when we had the elective procedure pause in March and April, we were about 50% capacity in a lot of our hospitals. And so that you just can't run them like that. We as soon as we realized that, we put the elective procedures back in. As we started to see the prevalence rise throughout Florida and the Sun Belt, there were people saying stop elective procedures. We did not do that. We let the hospitals function. There were some in harder hit areas like Miami-Dade that curtailed, but there were others in some major metropolitan areas, Central Florida. They continued to operate, and so we want to continue to do that for that. And so we talked about age-specific strategies. CDC just put out their best estimate for infection fatality rate, and they broke it down by age, which I think you've all said is very important to do when you're analyzing this disease. So I took kind of the fatality rate and then just flipped it to get a survival rate. So age 0 to 19, CDC's best estimate is now 99.997% survival rate, 20 to 49, 99.98% survival rate, 50 to 69, 99.5% survival rate, and then 70 plus, 94.6% survival rate. And so you see really dramatic differences between that 70-plus population and the younger population. I would say in Florida, the plurality of our deaths with COVID, and they are with, because if you test positive, it counts. It may not have been the cause. But of deaths with COVID, the plurality are age 85 and above in terms of all the age gradients that we've seen. So I think all of you have advocated mitigation policies focusing on shifting infections away from the at-risk group rather than suppressing society as a whole. Dr. Kaldorf, if you try to suppress society as a whole, is there an argument that that could actually increase risk to the elderly population?
Yes, there is, and it's actually been shown with some mathematical models by Wes Pegden and his colleagues, because if there's a certain percent needed for herd immunity, we don't know what that percentage is, but whatever it is, if there's a lot of old people in that group, we're going to have a lot of mortality, a lot of death. So if we do nothing, that's not good, because then there will be quite a high proportion of the old people who get infected. But if we do the same thing for everybody, we will sort of push things out over time, but we'll still have about the same proportion of each age group getting infected. So that doesn't help the elderly either. So what helps the elderly is if the young take this very minimal risk and live normal life until there's herd immunity. And then when we have herd immunity, then the older people can also live more normal lives.
And how would that apply, I think, to the colleges and the universities? I know around the country there have been some, pretty significant interventions on the college students. I know that they've done a lot of mandatory testing. I know they're doing a lot of aggressive quarantining college students. Some colleges have even sent the students home just on the basis of a positive test. How would you approach colleges and universities as it relates to COVID-19?
So I think that they should operate almost normally. So the students should be on campus, and they should go to in-person classes. If they get sick, they should maybe stay in the dorm room until they're well. If they have a cough, they don't need to be tested. I don't think there needs to be any testing at universities. So if they have a cough or some other cold symptoms, then they can stay in their dormitory room. They should certainly not go home, because they are then they're just putting their parents who are older at risk, rather than their classmates who are lower risk in their 20s or even less age. So the one thing that I think that we have to do with colleges is there are some professors who are older, and people 60 and above are at high risk. So it would make sense for those classes that are taught by older teachers, older professors, 60 plus, that they should be done online. The students could go to the classroom, and maybe there could be a TA there, but the professor should do it online. But for the rest, the colleges should operate more or less normally.
Jay Bhattacharya, I mean, do you agree with that? In particular, I know some colleges and universities have put a lot of emphasis on policing social life amongst undergraduate students, trying to limit, some of their gatherings or whatnot off campus. Is that likely to be an effective approach?
No, I completely agree with Dr. Goldorf. I mean, I think I saw, I think it was a CDC report that said there were some on the order of 50,000 cases among in 37 universities that are open, but only 2 hospitalizations and no deaths. Right, the risk is low in this college population. Opening up so that they can act like normal college students, it makes complete sense. Like, why would you prevent that? And in fact, there's a harm on the other side of that as well. So in the early days of the epidemic, there was a very sad story about from the Air Force Academy, where they essentially they sent many of the students home. The seniors they kept, and they required that they stay in their own dorm rooms, and two of the cadets committed suicide. There are severe mental health problems that come from the kind of quarantine, especially on young people. There's data that come out from the CDC that say that 1 in 4 young adults aged 18 to 24 seriously considered suicide in June. These kinds of policies to effectively quarantine young people are unnatural and are going to result in psychological harm. And I think colleges and universities have an obligation to respect that, especially given the fact that the kids themselves face so low risk from COVID. They face a higher risk, I think, from the psychological harm that comes from the lockdown policies that the many colleges have imposed.
They also face a higher risk from traffic accidents. So if you do like a comparison.
Sure, yeah, and I think I saw that same study, or the view of, I think it was over 60,000 positive tests for college students since schools have gone back. And for a while, there weren't even any hospital admissions, and I think there have been 2 hospital admissions. And that's also just not even getting into how sensitive these tests are, whether anyone was actively symptomatic or how many of them were actually infectious. Dr. Bhattacharya, how about applying kind of what you just said? How would you apply it to K through 12 schools? Should there be a lot of testing? I know that there have been instances in which a student may go to school, show some symptoms. Of course, that student gets sent home, but then there have been widespread quarantines of healthy students who may have been in the hall or been on the bus with them. How would you approach the issue of K through 12 schools as it relates to COVID?
I mean, we should use tests to save lives. We should use tests to create undue panic. Right, so that absolutely a student that is symptomatic, a kid that's K through 12 kid, a student that's symptomatic should stay home. Just like if they should stay home if they have flu-like symptoms or other symptoms. You shouldn't be spreading respiratory viruses around if you're symptomatic. Checking asymptomatic kids, the main purpose of it is essentially to close the school down. I mean, to create a panic and close the school down, I think. And the cost of that, as we discussed, are enormous, much more than a few extra kids, some extra kids getting COVID, because as we talked about, the risk of COVID to the kids themselves are lower. Now, that said, there are, just as with universities, there are some older teachers that face some risk. There, I think we should act creatively and work creatively to use our resources to protect them. So that maybe pair them with younger teachers so that the older teachers can help with curriculum support or classes online if it's possible. Things like that, I think are certainly worth doing. Again, the principle is let's protect the older folks so that they can do their work, while at the same time letting younger people who face very little risk from COVID itself and much more risk from the lockdown to go around with their work. So I think that same principle applies to schools. Opening schools up is safer for kids than keeping them locked down and closed.
And I think even the Washington Post put out something recently saying, they've been looking at the schools and have seen very, very little in terms of particularly secondary transmission. I think in Florida, you look and we haven't had that many generally because we have over 1.2 million kids in person now. But if a student does have it, the chance of them infecting, it's just not happening in any significant numbers. And I think it may go back, and maybe Jay, you can talk about. It got no play in the American media, but Iceland, they actually did a very creative study where they looked at how the disease was transmitted between adults and kids, and they looked at, I think, some of the physical structures of the virus that was identified, and they were actually able to determine which way the infection was going. Can you summarize that?
Sure. So the Iceland study, that's the set of that is done by this company called Decode Genetics in Iceland. They sampled a very large, I think it's like 12% of the Icelandic population in the report I read. And what they did is they sequenced the genome of the virus to look for mutations, which essentially provide a fingerprint in essence of the virus. So like if I infect you with the virus, you in principle will share most of the mutations of the virus that I have, that the virus infects me. You may have additional ones. So from that kind of evidence, you can figure out who infected who. A lot of these contact tracing studies, it's difficult to do that because you just know people were in touch with each other, but you can't tell who infected who. And they found a very low rate of children infecting adults in their study. What's striking to me is now that study has been replicated numerous times in numerous places. Children seem to pass the virus on to adults at lower rates than you would expect from your experience with other respiratory viruses. And that's really good news, right? So it's the kids in some sense pose less risk to the teachers in the classroom than the teachers pose to each other in the staff room. So I think that's really important to remember. I mean, I think so in terms of like how you design spaces to keep people to minimize risk without unnecessarily limiting activities. The kids themselves are at very low risk from mortality or hospitalization, and the emerging evidence seems to be that they pose much less risk to adults than you would expect.
Dr. Kaldorf, you'd mentioned the 15 and under in Sweden. The schools remained open during the height of their pandemic, and I think it was recently, it was either Sweden and Norway or one of the other Nordic countries put out a joint statement with Sweden saying, Sweden kept the schools open, we didn't. Sweden was right. They should have kept them open. And so have you been able to see, because we now know all of Europe, we see the United States, most of the areas have had kids in school for a month, 6 weeks. Is there any evidence that schools, K through 12, but particularly, the 15 and under, have been vectors of spreading the disease throughout the community?
There's no such evidence, and the evidence is actually in other directions. So in influenza, children spread the disease. So in that sense, COVID is very different from influenza. If schools were a primary conduit of the epidemic, you would expect that teachers would be infected more than other professions. But they did the study in Sweden and found that the risk to teachers was the same as the average of other professions. So that means that there is no evidence that schools are particularly spreading this disease. And I agree with Dr. Bhattacharya that if I was a teacher, I would be much more concerned about being infected by one of the other teachers in the staff room than by the children.
What do you think? Is it evidence-based for schools to mandate some of the social distancing for school children and wearing a facial mask during the school day in order to stop or limit the spread?
I don't think so. There are some things that make sense and doesn't have a bad impact. For example, if some of the lessons are done outdoors, being outdoors is good for many reasons. So that's never anything wrong with that. Making sure that the classrooms are clean is also a good idea for many reasons. And maybe it's a good idea to avoid the large school gatherings with the whole schools of hundreds of kids in the same room. So those are sort of very simple measures to take in addition to ensuring that children with symptoms are sent home. But to do more than that, I think there's no evidence that that would lower the risk to anybody.
Great. There's a lot of discussion always about just general testing and PCR testing, whether you should test asymptomatic people, just symptomatic, how many contacts. Dr. Bhattacharya, what is the this asymptomatic testing with PCR? But particularly, I think one of the things that's been put out, the New York Times had an article about a month ago looking at some of the test results in New York and in, I believe, Nevada and Massachusetts. And they found that because the PCR tests are so sensitive, that up to 90% of the positives were not identifying live infectious virus. And then I think there's other studies that have come out. I know Oxford's Center for Evidence-Based Medicine says that if you have such high sensitivity, you cannot be there's no guarantee you're even identifying live virus. And I think that, I guess, one, just what does that mean for some of the testing and the case numbers that we see? But then two, it seems to me that if you're test positive with no symptoms with a very sensitive PCR test, and they can't even tell you if you're infectious, we're quarantining across the country probably hundreds of thousands or millions of people who aren't even contagious. And I think that obviously has a huge cost to society. Doesn't seem to be getting a lot of discussion, though.
Yeah, I mean, I think that's a very important point. And actually, Dr. Levitt's a biologist, so he can tell us all about the PCR technology. But the key thing about the PCR technology that I think is important for this discussion is that essentially you're doubling the genetic material if it's present of the virus if it's present, right? If you have a very tiny amount of the virus, or if it's a viral fragment that's not actually that your body has successfully attacked, your immune system is successfully attacked, then what you're amplifying is something that's not going to pose any risk either to you or to others. So you're asymptomatic. The PCR, you're positive with the PCR. It's not a false positive in a technical sense, but in a functional sense, it's a false positive. Epidemiologically, it's a false positive, right? I'm not going to infect you, even though I have this even though I'm PCR positive, because it took so many doublings to reach the point that we can infer that there really wasn't very much genetic material for the virus present to begin with. I think that you're absolutely right to point out the cost of that when you attach it to a policy of contact tracing and isolation and quarantine. We effectively are quarantining people on the basis of PCR tests, a functional false positive PCR tests, where it will have no effect on disease spread because they're not infectious, and at the same time will impose enormous costs on them. Actually, there's another follow-on cost to that, is that it makes people less willing to cooperate with contact tracers because they know the costs. If I am contact traced and I'm asked to say who I've interacted with, I know if I say I interact with my friends, they're going to be facing the same thing. They might get quarantined, and if it's likely it's possible that it's a false positive, a functional false positive, then I'm imposing cost on them for nothing. I think in LA County, I saw an LA Times story that 60% of people who are contacted, who were put in touch with contact tracers, they won't cooperate with them. And you can see why. The cost of essentially ratting your friends out is enormous, or family out is enormous.
Dr. Levitt, can you talk about PCR testing?
Yeah, I just wanted to.
Yeah.
So, firstly, I agree with everything that's been said before. It's important to point out that PCR testing is not used has never really been used widely on the scale. And you can do a thought experiment about if during the flu season 2 years ago you had done PCR testing, you probably would have found that very large numbers of the population were flu positive, because really flu does get around a lot. So I think that we're basically not experienced about what it means to track a disease by PCR. We're also not experienced about what it means to track a disease by contact tracing. I think the problem with contact tracing for COVID and for all respiratory infections is that essentially you don't get it by touching somebody, you get it by being near somebody, maybe being in the same room as somebody. And as a result, there are many, many different paths of contact tracing. Diseases like Ebola, you really have to get very, very close to somebody. I think this was also true of the 2003 SARS. So I think somebody has said to me that contact tracing is expecting people to be wired together, whereas COVID is a bit like Wi-Fi. You know, you get near somebody, you feel their Wi-Fi or Bluetooth. But I think PCR, is interesting. I wonder whether we're going to use PCR for flu in the future. I think there were a number of novel things here that seem to make perfect sense and give people a feeling of empowerment, like contact trace, test everybody. But I think I felt from the very beginning that testing was, so there are certain people who really believe that testing is the solution to everything, and I'm not one of them.
But in terms of the sensitivity of these tests, I mean, I think when we were ramping up testing, and we were doing 100,000 tests a day in Florida at our height. It was just thought that if you test positive, then you're infected, and obviously, hopefully, the disease passes. But then with the CT values of 40, which is the standard, Oxford has looked at it. They think that you really can only be sure that it's live virus if you're in like the 25, 26 CT range. And so should we be reevaluating that and trying to do tests that are going to be more indicative, at least let us make a good inference that you're infected? Because it just seems to me that, you can test positive, they said, for 3 months, according to CDC, because they're picking up these dead fragments of the virus. And so how should we do that? Should we try to go for more sensitivity or less sensitivity? I notice in the clinical trials, they define a case not just as a positive test. In the clinical trials, you have to have either 2 general symptoms or 1 respiratory symptom and then have a positive PCR test.
Well, it depends on the context also, because if you're testing college kids, for example, you don't want to have a lot of false positives, or testing students and having a lot of false positives and doing a lot of damage to these kids, sending them home or closing schools. On the other hand, in a nursing home setting, when you're testing staff or visitors, there it could make sense to have a more sensitive threshold, because then it's better to be safe than sorry. So it depends sort of in terms of the context. And of course, in treatment, then the test is part of many other things to determine if you actually have COVID or not. So it's sort of what threshold you want to use depends on the setting.
But is this, in past infectious diseases, or really any diseases, do they ever define a case simply as 1 positive test without any clinical symptoms? Because, when we had a lot of drive-through test sites where thousands of people were going through at the height, and we started surveying the people about why you're getting tested. And in some of our most well-trafficked areas, 80% had no symptoms. They were either just curious, they were told that they should for work, maybe they thought that they may have been exposed or whatever. But if they test positive, there's really no other evaluation. It's considered a case, and then presumably they're told to isolate. And I don't know, is that how they typically have done it in the past without any clinical confirmation?
In medicine, there's a principle: you don't treat a number, you treat a patient. And I think we've made that mistake with COVID. I mean, what Dr. Kuhler said is exactly right. It depends on the context. You want a more sensitive case, a sensitive test in nursing home settings, less sensitive in other settings, because the losses are so different in the two different settings. In medical settings, you never treat a number. You always look at the clinical context around it. And so I think it's, in a sense, what you're saying, Governor, is exactly right, and makes good medical, sort of like folk medical sense. You don't want to diagnose simply just on the basis of a positive test alone. You want to look at the clinical context of the patient and then say, okay, how do I manage the patient? How do I treat the patient around that? If you treat a number, you'll end up very often making a mistake, because no medical test is perfect.
Great. I want to just get your guys' thoughts about kind of how the scientific and expert community has handled this. There's a lot of, when there's not a pandemic or not anything on the front burner, people may not be looking as much, to some of the folks. And I know there have been some folks out there that have built big social media profiles, got on TV a lot, all this other stuff. So what, what's the community done right, or what have they gotten wrong? And how open has it been to kind of evidence-based critiques of some of the prevailing narrative? Because I noticed that Professor Gupta from Oxford, one of the top epidemiologists in the world at one of the world's top universities, said that when they're producing research, they're having a hard time getting it published because a lot of the journals don't like the results, really, is kind of what I think she intimated. So Dr. Levitt, can you start and just address how the community has handled it? Have dissenting views been welcome? Have people been willing to reevaluate their initial assumptions from back in March?
I think that most of the scientific community basically didn't pay attention until it started to hit home. And at that point, I think they became panicked like most of the general community. I was disappointed that there wasn't more connection between, this is a hard problem. Knowing how to treat a novel outbreak of any kind is very, very difficult. And you solve hard problems by having discussions. You have solved hard problems by working them out face to face. And there's been surprisingly little communication like that. In my case, I actually sent reports to hundreds of people and basically got some positive feedback back, but most people said, you should stop doing all of the waters. And even recently, people have put out papers that, have basically said that I am guilty of practicing lethal nonsense. And if I have, it's certainly inadvertent. But I think that, any area, there's a certain level of common sense. And I think that looking at the numbers carefully and thinking about these things, everything we've heard here, for example, in treating age groups differently, makes complete sense. The need to let young people interact with each other, both for social reasons and for herd immunity, make perfectly good common sense. So I think there should have been more of that. I was very disappointed, and in some ways, one of the real pluses of this meeting that you've organized is that I kind of feel that I can, now consult with both Professor Kuldorf and Professor Bachahara about things that I'm interested in doing. I do think there should have been much more openness and much more understanding that we can all contribute into this. I think it's something which I really felt that in some ways humanity was facing a crisis, maybe self-induced by our reaction to COVID, but it required people to stand up and really try to make a difference. And I don't think it happened very often. I think Stanford, for whatever reason, is quite well represented in this field. But I think a lot of places have not done their duty.
Well, I would note, I think I read that Britain on the SAGE committee, they added Carl Hennigan and Professor Gupta from Oxford, which is great because they weren't there. Obviously, Neil Ferguson was on there, and I think that had they maybe been there, it may have been a better debate. And obviously, what happened in Britain really influenced the United States a lot.
Yeah.
Dr. Kaldorf, how would you analyze kind of the last 6.5, 7 months in terms of the scientific community? What does it say when someone like Dr. Gupta is having a difficult time putting out timely research?
As a public health scientist who has been working with infectious disease outbreaks for many, many years, I am absolutely stunned by the reaction of the scientific community as well as the media to this. And you mentioned, Dr. Sneta Gupta, I think, is the preeminent infectious disease ethnologist in the world. And until very recently, she has had a very hard time having people listening to what she's saying. You mentioned Dr. Hennigan also at Oxford, another infectious disease ethnologist who are favoring the age-targeted approach of protecting the elderly better while letting the young live more normal lives. And among my colleagues who are infectious disease ethnologists, there are many of us who quite obviously think that this is the right scientific approach. Dr. Baral, Dr. Chandler, Dr. Ludvigsen, Dr. Yi, etc. And including some who are afraid to actually speak out. So I wouldn't mention their names. But it's absolutely stunning how the scientific community has reacted to this. And most of the high-profile scientists have been not in infectious disease ethnology and infectious disease outbreaks, but in many other fields. And I think that as a scientific community, it's something that we're going to have to deal with for a long time, that there is going to be less trust both in science and in scientists. So that's something, once this is over, that we're going to have to work on.
Jay Bhattacharya?
I mean, I think I've been really, just like my colleagues, I've been very, very disappointed with the scientific community and the reaction, also the press as well. There have been open calls by fellow folks here at Stanford to establish, in effect, a censorship board over open science. It published in the New York Times. I've seen my colleague, Dr. John Ioannidis, one of the very top scientists, epidemiologists, infectious disease experts in the world, his videos that he's done suppressed. I've seen people attacked, scientists, respected scientists who dissent, attacked in the ugliest ways. And I've been trying to understand what is motivating it. And almost always the complaint is that if you have dissent or on this issue, that you're endangering the public. I mean, I myself have been attacked in this way as well. I don't understand how having open scientific debate could possibly endanger the public. Science is not a mechanism of population control. It's a mechanism for learning true things when you have a very complicated situation, and everyone in science gets things wrong. I mean, everyone. It's not possible, and that's why we have the open scientific debate, to correct one another. And I think that has fallen away in service of this idea that as a scientific community, we should convey a single message so that we get the entire public to do the thing we want them to do, or do the set of things we want them to do. I think that itself is an error, and it has really poisoned the scientific debate. And I agree with Dr. Kaldorf. I think it's going to take a long time to repair.
Going forward, I think you guys have put this out there, but just to kind of encapsulate it from both societal. Well, let me just ask it this way: when a pandemic hits, do all the other health problems in the country and the world all of a sudden stop? And if we're doing things to address the pandemic that's exacerbating those, obviously that's something that's very, very significant. So in terms of looking at public health as a whole, obviously doing some of the things that have been mentioned in terms of mitigating the effects of COVID, but also addressing mental health, some of these other lingering health problems that have only been exacerbated, is the way forward, to have an open society with those protections in place for those who are the 65 and plus, Dr. Bhattacharya?
Yeah, I mean, I think absolutely, right? There's really no choice. We are not simply bags of germs infecting one another. We're human beings that need many things to be healthy and happy. Public health to me has always been about that, is about promoting all of that. To make it just about and to structure society simply as a way to limit the number of COVID cases is a mistake.
Dr. Levitt, do you agree?
Absolutely. Again, I think a holistic approach is the only one that's fair. Otherwise, we're ending up privileging one kind of problem to another. And I think that, yeah, definitely, I agree with. Actually, I'm amazed at finding two people that actually agree with me. This doesn't hardly ever happen. Great, thank you.
Just in terms of, we are talking about going forward, can you say, I know you've looked at these, how the disease has been shaped in different parts of the world. You hear a lot of talk about second waves. And so obviously, Europe had the wave, the Northeast, Sun Belt this summer. Has there been any place that's had a true second wave where once the disease has really kind of saturated through society, gone on a real legitimate curve? Has it gone back up and spiked in any places? Because I looked around Europe, it seems like some of those places that they're citing didn't really see the disease in the first round.
Yeah. I looked at this quite carefully recently and basically tried to divide each epidemic into two parts if I could. In other words, if the number of cases went up and then went down again and then went up again, if there was a minimum between the two mountains, that was a way of deciding that there was a second part. Whether it's an outbreak or a wave doesn't really matter. But what was interesting was that the sort of saturation we were talking about, if it had been achieved in the first outbreak, then there could be many cases in the second outbreak in that same country, but generally almost no deaths. And in Europe, I think the only country I think that had deaths in its second wave was Moldavia, and that was because Moldavia had been not hit at all. I did the same thing for the USA, and again, it was only places that had been partially hit in the first wave that got hit in the second wave. So for example, Louisiana had a very extended outbreak, and it went on for a long time, or Mississippi. So I think you definitely have this feeling that each state seems, and in fact, both in Europe and in the United States, the number of deaths per case in the second wave was much lower. I think the number, it was maybe a factor of 10 lower. So in the United States, the second wave, and there really was a second peak in the cases. The number of cases was 5 or 6 times bigger than the first wave, but the number of deaths was actually slightly smaller. So we're definitely seeing this differential. So it does look like the second wave that's happened so far just seems to be filling in places that didn't, reach the saturation point before. Seems very clear.
Yeah, and I think you and I had talked about New Orleans. It was really the only place in the Sun Belt that got hit really hard in the first wave because they had Mardi Gras and millions of people there. So you had a real big outbreak, very high per capita mortality. But then when we had the whole Sun Belt see the increase in prevalence, the rest of Louisiana saw similar to what the rest of the region did, but New Orleans did not see the same as the rest. And I just thought that was very interesting. I think a similar analysis has been done. There was a town in Idaho that got hit really hard in March and April, I think partially because of tourism and skiing. And but that was not, Idaho didn't really see the full wave then. They did see it over the summer, and a bunch of places in Idaho saw it, but that one place that had already experienced it saw very little. So it's just interesting, as you're looking at this to try to make sense of it all. Dr. Kulldorff, do you agree? I mean, I think we've put it on the table, but going forward, you think that from a public health perspective, having an opening, functioning society with protections for the folks that are specifically vulnerable to this disease, do you think that's the best approach?
That's the right approach, certainly.
Great. All right, I have some reporters here, so our experts are on the line. If you guys have any questions, I know that they're happy to stick around for a few minutes and answer some questions.
Governor, we've heard the phrase herd immunity. That's become kind of a politically charged term. That's something to shy away from, or something?
Well, I think this is Dr. Calder. So basically, the question was about how this idea of herd immunity is like being used politically, and I think it's being used to say that you should just do nothing and just kind of let the disease do what it wants. I don't think that's what you're advocating. So can you talk about what your approach would be in terms of taking action, where the action is going to be the most beneficial?
Yeah, doing nothing would be terrible. That would lead to many unnecessary deaths among the elderly. So the key thing is that we have to do a better job in taking care of the elderly and protecting them through a variety of measures. At the same time that we should let younger people live their lives. And that's what makes public health sense, to have such an approach. In public health, we differentiate who are at the high risk and who are at the low risk, and we have to protect those at high risk. But to doing nothing, that would be a terrible thing.
And I think you had mentioned Wes Pregin and some of the researchers, and I think what they showed was most of the transmission occurs in kind of that 20 to 35 age group. So as more of them get basically asymptomatic infections, the ability of the virus reproduces really starts to decline because that's kind of the most active area in society.
Yeah, so some people are much more social and have more contacts. So those are the ones who will spread the disease the most. So when we talk, for example, about herd immunity, we don't know what the level is required for herd immunity, but it also depends on who gets infected. If a lot of elderly people who live by themselves are infected, that's not going to really help build herd immunity. But if the traveling salesman or the supermarket clerk or the taxi driver, if they get infected, then that really helps building immunity in the community. And it's obvious that in many places of the US, we have immunity in the community already building up. And Florida is one example. Whether it has reached the level of herd immunity quite yet, that's hard to tell, but it certainly is a lot of immunity in the community, and we're sort of well on our way to that point.
And I mean, would you say that, because there was the discussion between Senator Paul and Anthony Fauci, and I mean, is there a difference? I mean, herd immunity, I think, implies that like the disease is done, but I think that the role that population immunity has played thus far in epidemics waning, it doesn't mean that the disease is gone, but it's driven the reproduction. It's been a big factor in driving the reproduction rate below 1 in a lot of these areas. Would you agree with that?
Yes, and the COVID is never going to go away it's not going to be eradicated, so it will be endemic. But and we already always have new people who are born, and they don't have the immunity to it. So in the future, I would expect a lot of children are going to get it when they are 1 or 2 or 3 years old, and where this is not a serious thing. But I think the discussion in the Senate was about New York City, and certainly the reason why there are so few cases now is mostly because of immunity. And whether they have reached herd immunity yet, that's uncertain. My guess is that they may have reached it in the working class areas, but when the rich people come back from the Hamptons and the Berkshires, then they're going to hang out with each other, and then there's probably going to be cases from that.
But just to put a final point on it, I mean, I think that there's been a lot of talk, particularly in the press, about like when Dr. Atlas was being hit, saying he's advocating a herd immunity strategy. I think you've pointed out herd immunity is not a strategy. So how would you respond to that?
It's a national phenomena that every epidemiologist agree with exists, which we will reach sooner or later. So to call it a strategy would be to say like an airplane pilot is using gravity as a strategy to land the plane. I mean, if you're on an airplane, you're gonna eventually hit the ground no matter what. So the strategy is, should you do it soft landing so that everybody survives, or are you gonna do a crash landing, which is not so good? So you want to utilize gravity as a pilot. You want to use the gravity in a way that you can safely land the plane. And the same thing as public health. Herd immunity is there. The goal is to minimize the mortality until we reach that stage. The best way to do it is through a vaccine.
Which is also a herd immunity strategy. I mean, a vaccine, or not strategy, but the goal of a vaccine is herd immunity, correct?
Yes. So, for example, in measles, which is a very contagious disease, one of the most contagious infectious diseases, we need not everybody gets immunized. So there are some people who don't want to vaccinate their children, but they are still protected. Those children who are not vaccinated are still protected through herd immunity because almost every child is protected. And there's also some children who cannot get, they're immunocompromised, so they can't be vaccinated. So they're also protected. And the children less than age 12 months, they can't get the vaccine because it doesn't work in the infant. So they're also protected through herd immunity. So herd immunity is a situation where those who are vulnerable, in the case of COVID, that's the elderly, they can be protected because other people are immune, even though they themselves never were immune. Never were infected.
And next.
Living life like normal. That includes local governments have taken up mandates for masks and all that.
Yeah, it's a good. So I think the question is, I think all of you have talked about particularly younger people. I mean, we see the CDC survival rates. Under 50 is 99.9% survival rate. Under 20 is 99.997 survival rate. And so, given that, you've advocated, allowing society to function, allowing people to do so. The question was from one of the reporters: should that include, mandates to wear masks? Should that include mandates of social distancing?
So can I take that question?
Sure.
So
yeah.
I don't think that mandates to wear masks. The evidence doesn't suggest that they're particularly effective at slowing the spread of the disease. And what I have seen is that these kinds of mandates cause a lot of social strife. People in conflict with one another. That I think it's just as a public health matter, we want to avoid if possible, or as a policy matter. I think advising people that there are places where some kind of mitigation would be useful. If you're in a very crowded place, that wear a mask. I mean, that makes some sense. But just providing people the advice about what seems to work and what doesn't work, what's the uncertainty around that I think is the right policy. A mask mandate, as I said, I think scientific evidence suggests it doesn't seem to work. Providing people the right data, the right information, communicating it clearly, not sowing panic. I think that's the right public health policy here.
And specifically, I think we addressed this a little bit, but with like a third grader, not probably really significant vector in terms of infecting other people. I think the research shows, not that it can't happen, but certainly not a major portion. The mask requirements, to the extent schools do, in Florida it's mixed on schools requiring it, but is for source control. We're told CDC has said no evidence it will prevent you from being infected, and that there may be helpful for source control. And I know there's a lot of randomized clinical trials that were done prior to this epidemic, which would probably say even that is a little shaky. But nevertheless, that's where we are. But for specifically like a third grader, a mask mandate there, should that be a parent's decision? Should that be just something that schools don't do? Or do you think that that's a good thing for them to do?
I mean, I think for third graders, it doesn't make a lot of sense to require a mask. I mean, there's a school of thought that like if you use the mask incorrectly, you actually could make things worse, right? So you're touching the mask because it's uncomfortable. You're going to touch you end up touching your face. And for third graders, we don't have any evidence at all that they work in slowing the spread of the disease. I mean, I think a trained surgeon wearing a mask in a surgical room, I mean, absolutely, they're not going to touch their face. They've worked really hard to suppress that habit. It's hard enough for adults. I think for third grader, first grader, I mean, I think that for that, in that setting, the evidence that it slows the spread of the disease is non-existent. And I think there's a lot of I think it just causes problems there's not enough benefits to require.
Great. Next.
Are they asking you to reopen society, or are you listening?
Well, I think the question about, first of all, we're the most open large state in the country by far. We opened at the height of the infections when everyone was saying shut down the state. We didn't do that. We actually opened Disney World. Now, Disney could have opened earlier. That was when they chose. People were saying, oh, well, how could you do it? Well, what happened is Disney opened, and infections have gone down, hospitalizations have gone down, and that's just been the case. And so really, I think the final thing is some of the local restrictions, mostly in southern Florida, but every business from a statewide perspective is able to function, and we want to continue to do that. We also have the ability. We've done a lot on long-term care and nursing homes. Some of the things, though, that we've learned is, okay, we didn't allow visitors because we didn't want the disease to get in. But you look at health holistically, that's really negative for some of these folks who need to be with family. And so we've opened that up for visitation. We're going to look to continue to do that because their health and well-being, apart from corona, is very, very important. But we also now have the ability with point-of-care testing. I actually, because I'm going to be with the president later today, I don't want any of these tests. I don't think I should have to test. I'm asymptomatic. They make you test. So I tested this Abbott. It's like a little card. You do it, and it's an antigen test. We're going to get millions of those over the next couple weeks. And so we'll now have the ability, similar to what Professor Kaldorf said, okay, you have a college student who wants to go visit their grandparent. Well, normally we may say, I don't know. Well, now we'll be able to do that, and you're going to be able to do that. So I think the protections are going to be better for the elderly because of some of the technology that's happened. And I would also say, and I think this goes to both for something that Jay Bhattacharya said about the difference between mandates and providing people information to say, here's the things. If you look at Florida's infections, elderly 65 and older are underrepresented from their share of the population. People in their 20s and 30s are overrepresented from their share of the population. That, I think, is what we tried to get, thinking that we can't have zero infections. We know there's going to be infections. Shifted away from the elderly. Some of that was what, the nursing home and long-term care and all that. But some of it was just folks heated in the 65 and up. You had senior communities like the Villages. They kept the lifestyle active, but they did it in ways that mitigated the really significant risks that were there. And they've had very, very low prevalence, very, very low, fortunately, mortality. And this is a community of 125,000 active 60-plus seniors. And so I think that showing folks, providing that evidence, letting them understand the risk, and then trusting them to be able to make behavioral changes so that, one, they still live good lives, but then they're taking account of some of the risk. And I think some of our retirement communities did a really good job of that in Florida.
On the long-term care.
Well, first of all, I'm happy to answer, but is there any more? We've got our experts here. Is there anyone else that has a question that they can address? Yes, sir.
Yeah, I'm wondering if they might be able to critique Dr. Fauci's handling of the pandemic.
Great. So the question is how would you, I guess the word was critique, but it doesn't have to be critical, of how Anthony Fauci has handled this. I mean, I think that, you know, the back and forth with Senator Paul. You know, Senator Paul obviously believes, I think Professor Kaldorf also said, you know, New York went down because there was a saturation in the population, maybe not herd immunity, but certainly that helped drive it down. I think Dr. Fauci said that wasn't a significant factor, that it was more hand washing and crowd control. So how would you critique that exchange, but then just generally in terms of pandemic management? Who is anyone want to take it?
One thing that's very important to realize is that infectious diseases are very complex. So there's not one person who is an expert on infectious diseases. Because there's the sort of the science of it, of virology and immunology, there's how do we treat patients, and then there's the public health aspects. So Dr. Fauci is a very eminent immunologist. So if you have questions about the immunology of any infectious diseases, he's a very good person to ask those questions to. Don't ask those questions to me because I'm not an expert in immunology. My expertise is in the public health aspects and how infectious disease outbreaks are detected and how they spread and so on. So different people have very different expertise within infectious diseases. So as journalists, I think it's sort of important to see, okay, I have these particular questions about this particular thing. Who are the scientists who are actually the experts in that particular area versus another area?
Jay, anybody?
I can take that a little bit. I mean, I think to echo Dr. Kuldorf, in early February, March, I mean, Dr. Fauci's been involved with infectious disease control for a very long time. He is a preeminent scientist for good reason. I mean, he is an expert. But I think we, in the early February, March, we sort of put on a pedestal to essentially give his knowledge about a whole range of things, some of which was in his control and knowledge set, and some of which was not. And I saw him a few months ago I think it was another Senate panel where he very humbly said, "Look, I'm giving you my expertise as an infectious disease expert on how to manage this disease. I'm not looking at the broader policy context." I think science, we think about science as like giving us all the answers, but that's the mistake. What science does is it tells us if we do A, we might get B. It's up to us, I mean, as not, I've been taking my scientist hat off, as non-scientists to make a decision, do we want to get B? Or if we know the cost of getting B or C, D, and E, right? So do we really want zero COVID? If you get zero COVID, I mean, I don't know if it's even technically feasible, but we know that we're going to have to destroy our society in order to get it. We'll have to get rid of all of our freedoms. We'll have to make sure that very few people interact with each other. It essentially is so high a cost that it's not worth it. Science can tell us, okay, here's how you would maximize our probability of getting zero COVID, but it's up to us non-scientists to decide whether it's worth it. You can't put one person on a pedestal and ask them to make that decision for society. And I think I love that I live in a democratic society where those kinds of decisions aren't up to experts. It's up to people deciding together through electoral processes what we value. And I think is something really important to remember. We shouldn't elevate one person as sort of as the arbiter of what all the right things to do on infectious disease. So even beyond what Dr. Kuldorf said, which I completely agree with, I think dealing with this infectious disease is a fundamentally democratic matter, and we shouldn't just be looking to scientists to have this conversation.
Yeah, and I mean, I think the one time when he was asked about all the 60 million unemployed, and he referred to it as an inconvenience, and look, from a elected official, it's not an inconvenience. I mean, that is life altering for many people. It's caused businesses, small businesses, to go out, people losing jobs. Now we've worked hard to get that back in, but the idea that is not a major concern if you're only focused on one particular virus, maybe it's not a concern for you. But obviously, you have to consider the whole enchilada, and that's been something that I think when you get that, you got to balance that about with other things. The one thing, though, I just asked you to comment on, Jay, because I think it's kind of symbolic of some of the problems that I think some Americans have had. But with like the mask. So Fauci was asked 60 Minutes, shouldn't be people wearing a mask. He says, look, in an outbreak, it may make you feel better. You may think that you're protecting, but it's not really offering you the protection. And then all you're doing is touching your face, touching the mask, and you may even be able, I think he implied, increase infection. And I know there's been studies that said cloth masks can do that. So that was kind of it. And I think all scientists were pretty much saying that. Now many say, basically, mark of a good person, are you wearing it or not? And it doesn't seem like the underlying evidence has really changed very much. And so, what is kind of the average person look to see when they were literally tweeting at you, don't wear a mask? And the explanation that, we wanted to save them for healthcare workers, I don't think that flies, because healthcare workers aren't wearing cloth masks. They're saying, CDC saying, wear the cloth masks now. So something changed between March and probably about May or June. It doesn't seem like there were any new RCT studies that had come out, though. Jay?
Yeah, sorry. Yeah, I was unmuting. Yeah, so I agree. I mean, I haven't seen a ton of evidence that suggests that I would have expected to see a lot more study about the kinds of masks people actually wear. And I haven't really seen that. It's possible I missed it. I can't read the entire literature, but if someone can correct me, I'd be happy to be corrected. But I haven't seen any studies, Governor, along the lines you're suggesting. It'd be a really good idea, right? Because that's something that the public health community is saying we should do to keep ourselves safe or keep others safe. Checking to see if the kinds of masks people actually use, not the ones we would hope that we prescribe them to use, do they actually work? I don't know. I don't think I've seen any studies that suggest that the typical masks that people use that they use and reuse, often without washing them or whatnot, are those effective? I don't know. I mean, I think people like masks because they're intuitively, you think, okay, I am giving droplets out to you that might be infected, might have the virus, and so it's got to provide some protection. I mean, I guess intuitively it might, but it's still, from a scientific matter, it's an open question whether they do or not. And often in science we end up with results that are not intuitive. We were surprised by the experimental results. I think this may be one area where, I guess you could probably hear my reticence to weigh in, because I don't know of a ton of studies that have definitively said one way or the other on this, and that's actually a problem. I think there ought to be more if we're going to create this into this talisman that we have to wear in order to be a good person.
Well, and so Denmark they have completed, I think, the only randomized clinical trial that I'm aware of. It's been done. They said it was going to be published, I think, by the end of August or beginning of September. Still hasn't been published. So I think that would be useful to be able to get those results. It was a pretty widespread study, and I know Denmark, they've gone a certain way on that, but that was really the only one. And then most of the other ones were influenza, which I think would probably be a useful analysis as well. Do we have other questions for some of the doctors?
Actually, Governor, if I might be able to follow up on,
sure.
Dr. J's comment. I'm wondering, he seems to suggest that policy and politics should control health and how you respond to a virus outbreak.
So the question was based on Jay saying how responding to a pandemic needs democratic legitimacy. I think that's what you were saying. It's not just a matter of taking an unelected expert and then having them make all the decisions. I think the question was are you suggesting that it should be more about politics, or is it policy? I mean, I guess what I would say is these are fundamentally policy questions, which you take into account scientific views about the virus. Although I would note, and you guys know better than ever, when people say trust experts, there's experts that disagree. And I think what often happens is there'll be a narrative that's set, certainly in the press. They will find someone with a credential that buttresses their narrative, and then they will act like dissenting from that means you're ignoring experts when there's experts on the other side, just as credentialed, many times more so, who may disagree. So some of that is there. But what would you say about, is this a policy response, or should you really be finding like a health official, putting them in charge, and then having the elected official just simply defer on all these questions?
Yeah, I mean, we don't live in a dictatorship, and that's a very, very good thing, right? I think the key thing is what you said, Governor, is that it's a policy question. If you think about what policy means, we consider the broad set of costs and benefits of a particular policy when we make decisions about it. We may just differ on what those costs and benefits are, but we certainly, if we're serious people, consider both costs and benefits. A lot of the discussion around lockdowns have focused mainly on the benefits, the slowdown of disease spread, and have ignored the cost altogether. And emblematic of that is elevating public health officials as if, or public health officials only care about about COVID control, as if that should determine policy for all of society. In the United States, we have politics has to play a role. I think there's no other choice in some sense. It doesn't have to play an ugly role. We can sort of discuss openly what we value, and our elected officials can help, can make decisions around that, and they pay and as you well know, Governor, pay the consequences for getting it right or wrong that the voters will give you. I think that's the only choice in a democracy. There's no other choice. If we decide to cede that, then we've decided to see what else are we deciding to cede? I think elevating scientists to the role of sages who know best for everything about society, that's a mistake. And that's why I was uncomfortable with answering the question about evaluating Dr. I mean, I think he said that he just cares about disease control. That's what his expertise is. That's what he's been asked to do. When we shouldn't be asking him to do this widespread policy, this broad policy decision making. That should be left up to our elected officials. That should be left up, advised, of course, by the scientists, as you say, on both sides, so that you understand that there's uncertainty around what we're telling you. I think that's the right role for scientists in a public policy setting. It's not.
It's interesting. If you go back to Eisenhower's farewell address, people remember it for warning about the military-industrial complex, which was obviously prescient at the time. But he also talked about the need, when you're dealing with experts, scientific experts, that you use that expertise to inform policy, but you don't let your policy be displaced by them. And he specifically warned about that because he made the point that, any one expert is only going to have certain amount of knowledge about a specific part of society. But him as president, he had to deal with and he dealt with the 57 pandemic. And so you have all these other things that you have to have consideration. So when you have someone who's an infectious disease expert on the task force, maybe you should also have an economist on the task force. Maybe you should have some other folks like that to be able to try to get at the decisions that are best for society as a whole. We have any other questions?
There does seem to be, but I want to make sure I understand. You believe that those protections for the elderly would include testing, visitors at nursing homes,
So
be mandated testing
So maybe Jay, you could take this. The question is protections from the elderly. What all does that entail? For example, should you mandate that any visitor get tested? So in Florida, we have not done that because we're focusing on a symptoms-based approach and then having them wear adequate PPE with appropriate distancing. But what would the role of testing be for visitation? And then maybe beyond just that, in the broader senior community, what other policies do you guys think make sense?
Yeah, so I think testing can play a role, especially with the development of these rapid antigen tests. They're the nice thing about them is they're very, very inexpensive and they're fast. And so that could play a very, very important role in protecting the elderly if we implement it right. I think it's hard to say that what you do. You have one set of policies that's in place for literally every single nursing home and every single. I think broadly speaking, you should use the resources you have so that you can protect the elderly, right? That's the key idea. So if in a particular nursing home, the kind of policies involve testing all the visitors. Actually, one very important thing is that many nursing homes share staff with other nursing homes. Like the same person working in nursing home A will also work in nursing home B. So so regulations around that kind of that kind of like shared staff might be useful. I've heard that about these like COVID only nursing homes. I think creatively, I think this is a hard problem. I think Dr. Levitt said this is a hard problem. I completely agree. But I think we can think creatively about how to use the resources we have, including testing resources, to try to address it. And I think actually what you pointed out, Governor, is true. I think to a large extent, I think Florida has been more successful than much of the rest of the country. Florida famously has a larger fraction of the population elderly, yet the proportion of mortality for among the elderly population from COVID has been lower than much of the rest of the country. I mean, I think that points to some success in policy. And of course, you could do better, and we should, as new technologies arise, to try to do that.
Yeah, I think we've had biweekly testing that the state was underwriting at all 4,000 of our facilities for staff, and we've got the positivity rate on that has been below 1% for over a month, which is obviously good. CMS has issued a mandate for nursing homes, which is kind of displacing what we were doing. So they sent the point-of-care antigen test, and then you have to test the staff on certain cycles depending on the overall prevalence in the community. And so if it's low prevalence in the community, you may only need to test the staff once a month per what they're doing. If it's high, you may need to test them every week, or maybe even more than that. Clearly in Florida now, we're looking at much less prevalence than when we were in the end of June and July, where we had, we had cases in, I think, a huge number of these facilities. Now that number has gone down very much. And then I think with these Abbott point of care, 15-minute doesn't require a lab. That is really going to be able to give us, I think, some good, and not just for nursing homes. I mean, you could see dispatching that to the villages or some of these other places, so that if they do have, a granddaughter come, okay, you have the access to that. And so they're going to be producing tens of millions of those very, very soon. So I think that it allows us to offer protection, but also allows them to even live a fuller life by using this appropriately.
Back to the college pressure gathering at a large party and positive. Is that going too far? I'm happy to hear from them.
Yeah, I'll address it. So, Dr. Kaldorf, maybe you can take this. There's a question about a university in Florida where sanctions are being threatened against students who go to parties above a certain number of people. And then what else is there?
If you test positive.
Okay, and then mandatory self-isolation, so you could potentially be suspended, I think, or expelled if you test positive and don't isolate. I would, if I were a student, I'd ask what the CT value of the test is so that I would know. But what do you think about that approach?
I think it's terrible. I think that the young people should live close to normal lives. And as long as they don't invite their grandmother to those student parties, I think that's fine, but keep grandma away.
Yeah, so what I would say is, I think I agree with the experts. Let's protect the faculty members. Let's focus on the things that we can, control, kind of policing them off campus. I just don't think that that's likely to be effective. In terms of the testing, I think this is a huge problem. If you can get a positive test with no symptoms and the test cannot tell us whether you have live virus, I think it's a big problem that you're asked to isolate. It's one thing if the test, maybe it's a little less sensitive, says you have live virus. I'm totally fine with isolating under those circumstances. But no symptoms, CT value of 40, maybe picking up dead virus, and you just sit in your dorm for 2 weeks? And so I think it's a big problem with these tests. We're looking at it. We're talking to the FDA about it. But I think if you don't have symptoms, if that CT value is above 30, it's very problematic to then be isolated, because I think you're isolating healthy people. I think you're isolating people who are not actually infectious and contagious. And that New York Times article was astounding, that 90% of these cases it was New York, Massachusetts, and Nevada. It got almost no play, which is odd. I mean, the New York Times is kind of like, the Bible for the mainstream media, and yet you didn't see any play off of it. But that has such profound implications for how society is governing. And again, I mean, I believe, look, if you're at risk of infecting people, you need to stay home. I'm 100% supportive of that. But the fact, I mean, if someone tests positive and it's dead virus from 2 months ago and they have 0% chance of infecting anybody, to just keep them in a dorm room or wherever for 2 weeks, I think that's a problem. I don't know what sensitivity testing they're using, but I would recommend that they're not doing that at 40 CTs and then doing the isolation. Anything else?
Do you feel as though higher healthcare services, I right now, my first inclination is to get a COVID test. PCR test, and if I test positive, I'm going to be told, isolate for 2 weeks. Should patients have to get tested if they're asymptomatic?
Well, let me ask the experts. Do you think that going into a hospital for something totally unrelated to COVID, maybe a scheduled procedure, should that be contingent on taking a PCR test to get a negative PCR test?
I think that partly depends on the infrastructure of the hospital, right? So if you can't, if you suspect someone has COVID, for instance, they're symptomatic with things that look like COVID, yeah, they absolutely should take precautions at all. Your question is about whether, let's say I need an eye surgery. Do I need a negative PCR? And I'm completely asymptomatic. Do I need a test? No, I think the answer is no. I don't think you need to test the asymptomatic someone who's going to a hospital setting in a ward where in a place where they're because they're very unlikely to be passing the infection on to people, and the people that are going to be treating them will all have PPE, all of them. So I think effective PPE, much more effective than the general public. So I think that's probably excessive. Now I can understand some hospitals that don't have structures in place to protect the people that work there. I'm not saying that should be a rule. You don't do it. I can understand hospitals that might want to do it, but to require that happen for every single person. The reason I say that is because there are costs to that. People will not get. We call them elective procedures, but they're vitally important for health, right? So people will stop getting colonoscopies because they don't want the COVID test. They'll stop getting all kinds of procedures that are vital for their health. There's a cost to that in health. So the question is the benefit worth the cost? I don't think so in general. I can think of situations in hospitals where it might be worth it, but it'd be a specific situation for specific hospitals, not a general rule.
I think part of it is, obviously there's a legitimate concern with not seeing spread in hospitals. That's for sure. But I think, as Dr. Bhattacharya points out, some of the hospitals are situated where they clearly have COVID wings versus just things that aren't, where you're not going to see that mixing. I will say this, though. I think it's the way CARES is structured that if you go in for some type of non-COVID related procedure, but you pop positive for COVID, that is a COVID patient for them in terms of reimbursement. They report people hospitalized, being treated, and incidentally. And so you end up having a situation at the height of the outbreak in Florida over the summer in Miami-Dade, Jackson Memorial, 40% of their, quote, COVID patients were not in for COVID. They were in for something else. They got swabbed, and then they tested positive. Many of them were asymptomatic. So I think it's a good faith attempt, by and large, to prevent disease spread, and I understand that. But I do think that there are costs. If sometimes people, some of this stuff's timely, the delaying of a lot of the cancer screenings that we've seen throughout the country. And a lot of it was not even because, some of it was because of the electives, but that was really changed in a lot of places like Florida very early because we realized it was a mistake. But you still saw a decline. It's still not where it needs to be. And that's not going to manifest itself in mortality this year, most likely. Maybe not even, it may take 4 or 5 years to fully see this come to fruition, but it is going to be problematic. So one of the things we've tried to do, we're going to continue to do, we may even do a little bit more in terms of public service announcements is, I mentioned the statistics. We have about 3.5% of our licensed beds have COVID patients. Obviously, they're important. You know, we care about them. We want them to do well. We've got a lot of empty space in the hospitals. And if you have any, if you need screenings, if you have heart problems, if you have this, we can see you. You can get care. It's safe. Very few hospital workers were infected, even at the height. They did a really good job limiting spread in hospitals or even keeping it completely out of many. So going in to get those procedures is very important. Don't sit on, I mean, I think in Britain, there was an article about how they had a huge increase in people dying at home over the last 6 months. And the question is why? Well, those are people who probably have heart attacks that aren't going in. Either they're scared of the virus or maybe they just don't think they can be seen. And the results have been really, really significant. And I think at the end of all this, well, let me ask you guys, Dr. Levitt, do you agree that, you know, once the people look back on this, obviously we know COVID is causing, deaths in folks. But I think we're probably gonna see some deaths that were a result of a combination of fear, combination of, you know, some of the changes in society. And those are, I think, deaths that aren't being discussed right now. Obviously, I think those are, unfortunately, things that we're going to continue to see. Do you agree that the effects of some of the panic and the fear and the mitigation are also going to have negative health impacts?
Without doubt. I think that even just economic downturns lead to extra deaths. So I think that all of these things will have an effect. And throughout all of this, we've been counting a life as a life. But certainly, as a grandfather with a 17-year-old grandchild, I think his life is much more important than mine, because I've lived my life and he hasn't yet. And I think that there are all these considerations that need to be taken care of. I think that what's impressed me very much about hearing people who do public health, as both Professor Bashahara and Professor Kulov do, is they have a very nice wide view. It's not like we only care about COVID, they care about everything. And I think that's what you need to do. So I think there's going to be, you know, in some ways I see there's been a tear in the fabric of society. I mean, people, you know, things, we talked about this when it comes to academics interacting. I think we've seen amazing polarization. I think that, you know, maybe it's a wake-up call, but it's certainly worrying. I think that, you know, I really feel that as a society, and it's not just the USA, it's all of Europe and other societies as well, I don't think we've really shown our best side in this. And I think the media has been irresponsible. I think that, you know, I'm very partisan. I think that it's been very, very difficult. So I think that we are going to see a lot of problems downstream. I've heard, for example, of very sad cases where children who need to be, who have seizures because of insulin problems, if they don't get treated, they become quite severely brain damaged. And there's probably thousands of such kids worldwide because of this. And, you know, there's lots of things like this. So I also worry if even during the epidemic, we didn't see excess death that occurred coincidentally with COVID, but was caused perhaps by people not getting treated for critical health issues like heart attacks and things like that. I was just talking about it before we came on, and this all needs to be analyzed, but I'm sure there's going to be this situation.
Dr. Kaldorf, how would you weigh in on some of these other health effects? I mean, I noticed one thing, and I know you know a lot about Sweden, given your background there. There was the exchange yesterday with Dr. Fauci and Senator Paul about Sweden having lower per capita mortality than the U.S., than Britain, than Spain, than Italy, Belgium, all these places that locked down. And Dr. Fauci's response is, well, they have higher than the other Nordic countries, which I think for tag COVID, I think is true. But I think if you look at the excess mortality so far this year, compare Sweden to the Nordics, I think it's almost exactly the same. And do you think that's because Sweden minimized some of the other types of fatalities by keeping their society functioning? Is it a coding issue with COVID?
It's difficult to compare countries because of a variety of reasons, coding and so on. And also within Sweden, there's big difference. So Stockholm, for example, have much higher rate than the rest of Sweden, even though the strategy was identical. So it depends a lot who got it first. I mean, New York had very high rates, and that's partly because they sent sick COVID patients back to nursing homes, infecting other patients. But it's also because they were one of the first infected in the US because they had a lot of international travel. So there are many of those things that plays around with who are mostly affected. Eventually, the excess death is what we're going to look at. And the excess death in Sweden is much lower than the number of COVID deaths. So certainly, but there are reasons for that also. But I think this collateral damage on other health is a really major problem because we don't go to the doctor for the fun of it. We go there because we need help with treating a disease, with preventing death, and living a better life health-wise. So when the number of visits to the doctors and to the hospitals goes down, there is obviously a negative effect of that. Now, some of those negative effects are immediate, like, for example, if there are increase in suicides, we see that immediately. But most of them are not immediate. And in public health, we have to think not only about the present, but also about the future. So, for example, cancer screenings have gone down. Now, that doesn't increase the number of cancer deaths this year, but somebody who will now maybe die 3 years from now because they didn't get the screening instead of dying 10 or 20 years from now. So those things are going to be, we can't measure those in terms of mortality right now, but they're going to be with us for many years in the futures. And I think that's very unfortunate.
Great. I just want to also say, we are also, I think, to go to your question about the universities, we're looking at perhaps us, if there's something we can do at the state level to provide some type of Bill of Rights for students. And I understand the universities are trying to do the right thing, but I personally think it's incredibly draconian that a student would get potentially expelled for going to a party. That's what college kids do, and they're at low risk. And I just think that we've got to be reasonable about this and really focus the efforts on where the most significant risk is. I do think it's very important that we do have the campuses functioning and kids back. And I think our great experts here, I don't think either of their universities are actually open for in-person. So if you guys really want to have in-person, we'd definitely be able to find spots for you in Florida. So just let us know at some time on that one. But we really believe the in-person instruction is very important, both from an academic and from a socialization perspective. So we are looking at that. And we'll make a determination if there's a way to go to be able to do that. Now, and I will give our university credit; they have not gone way overboard the way some of these others throughout the rest of the country. I mean, some of these stories are just absolutely horrible. And just if I were a parent, to have a student treated the way some of those colleges and other parts of the country have treated them, I'd be none too happy on that. But there may be a better balance to be struck going forward. Anything?
A little more artful earlier. Are you really planning on, easing the restrictions that are in place, or how seriously are you?
Well, we don't have. I mean, we really don't have very many restrictions. I think
restaurants 50%, bars 50%.
Oh yeah. Well, okay. So restaurants are going. Well, we're going to do two things. We're going to preempt closure of restaurants from local. And this is evidence-based. I mean, we had an A/B test. Miami-Dade closed them at the height when everyone was really panicking at the beginning of July. Broward didn't, right? Broward kept indoor dining. I challenge you to show me a difference in those epidemic curves. In fact, I think Broward probably went down. They're both dense. counties. They both had significant epidemics. So I don't think that the closure of restaurants has proven to be effective. I get how you could potentially have spread there, but I also have to look at that. And I think that they've been going on, they've been able to use outdoors, but we can't have these businesses dying. So they're not going to be able to be closed by locals anymore, and they will be able to operate at the capacity that they're comfortable with. So that's going to happen. And then with the bars, we obviously want them to just, and it's not even, I don't necessarily blame them, but I think when you have situations where the restaurants are saying, hey, wait a minute, we're doing all this, and they're not, but I think that those are obviously, many bars were operating, though people forget, all they did was they started serving some food, but you still had bars throughout the whole state except for the 3 southern Florida counties, but those are local restrictions. And so that'll be there, but then everything else, I mean, obviously we have universities, we have schools, we have all the outdoor theme parks, all that stuff. Those limitations on capacity like Disney, that's self-imposed. I'm supportive of them going to greater capacity, and I think that they should do it. So really, I think the message is, Florida open. In fact, we were more open at the height than we were a month before this summer with some of the theme parks, and then we're going to continue to do it. But I really believe this. We've worked great with locals. We understand different problems, and we've given them a lot of latitude to do things that I personally wouldn't have done. But I think that that's the way to do it, bottom up. At the same time, I think everyone in Florida has a right to work. Everyone in Florida has a right to operate a business. Now, there can be reasonable regulations on that on a local level, but to say no at this point from a local perspective, I don't think that that's viable. So I don't think it's as much as the state having restrictions as much as we may need to provide some level of assurances for people against some of the local restrictions that we've seen.
Governor, I have a question about the CARES Act. The state chair of the CARES Act, their counties are concerned that they haven't received the remaining 75% that they were promised earlier.
So here's how that works. So the big counties got it directly. They got a lot of money. That's on them. If they misspend it, the federal government comes at them and they take it from the county. All the counties below that threshold, I think it was 500,000 or less. If they misspend it, the federal government comes after us and we'll just take money from the state. So what we've done is we've given the money, we're making sure that they're spending it consistently, and as they request more, we'll send it out. But what we can't do is just say, here, take it, spend it on what you want, because then I'm putting the taxpayers that pay it to the state at risk. And so nobody is not getting money when they need it. I think it's just a matter of, okay, once you need it, once you show us what you're spending it, we'll give it to you. I'd like to give it all, but I don't want to be in a situation where a year from now, I have the federal government just take $600 million or something out of our kitty. I think that would be a big, big problem, particularly with the revenue declines we've seen. Not as bad as forecasted, and I think we're going to continue to hopefully rebound, but it's a serious, serious issue. And if I wasn't responsible for it, I'd let them do whatever they want and kind of take their chances on it. So that's really the issue, is just being able to do the oversight with it. Let me just thank our guests for coming. I really appreciate your willingness to take the time out. I think these are really important issues. I think you guys have really tried to approach this from an evidence-based perspective. I've seen different writings and different things, and I think all of you, as new information comes up, I think you've always shown the willingness to reevaluate what we've learned, and I think that that's very refreshing to really let the evidence lead. In politics, you kind of reach a conclusion and then try to marshal whatever observations you can get to support the conclusion. In science, you really let the observations drive the conclusions, and I think that that's what you're doing. And so I appreciate you guys coming, taking the time, and thank you for being willing to answer questions from the media here. So, like I said, if you have the itch to teach in person this year at any time, even if it's on a visiting basis, we got a lot of places where we'd be happy to have you in the state of Florida. So thanks so much.